Hello, I'm Susan Cole from Phoenix Health Movement,
I'm Dennis Sango from Africa Advocacy Foundation.
and welcome to episode 3 of Positive Health, the live broadcast series focused on HIV and the pressing issues affecting Black communities. We're joined by two absolutely amazing guests for this episode. We have Angelina Amoeba, who's been living with HIV for more than 30 years and has over 25 years' experience working in the HIV sector on a wide range of initiatives, ranging from providing one-to-one support to people living with HIV, treatment advocacy, managing service delivery, speaking at conferences around the world, and sitting on various and international advisory boards. She's a founding member of the 4M network of mentor mothers living with HIV and co-author of Our Stories Told by Us, celebrating the African contribution to the UK HIV response.
And we are delighted to have Dr. Annabel Mimo, who is a doctor, academic, activist, and writer. She is an NHS consultant in Sexual and Reproductive Health, founder of the Reproductive Justice Initiative, part-time PhD candidate at King's College London, co-authored several academic papers written for numerous outlets, including The Guardian. She is also the author of the multi-award-winning book, Divided: Racism, Medicine, and Why We Need to Decolonize Healthcare.
Wonderful. I'm very excited to have them both on, and it's great to have a doctor joining us because my blood pressure at the moment, because Annabelle literally turned up 1 second before we went live. So yeah, it's not just the menopause that's making me feel a little bit hot today, but there's been lots going on in politics in the UK this week. But one thing that I think is actually really interesting is that there's been the launch of the NHS 10-year plan. It seems that things are going to be going more digital, prevention focused, and more community based services, which sounds really interesting, and tackling health inequalities, both in access and outcomes, is mentioned within this strategy. So that's actually really good. And I'm really pleased that HIV is specifically mentioned within the plan, which is fantastic. However, we know that health inequalities affecting Black communities has been around for generations, particularly for Black women who face intersecting forms of disadvantage. So it's not going to be an easy fix to address these health inequalities. I think it's really important that when they look at this plan, they take into consideration all of the different drivers of the health inequalities that we're seeing. And also, it's really understandable why some people in our communities are untrusting in terms of what's been happening in the healthcare system. So it's really important that the NHS works in partnership with Black communities in terms of addressing all of these inequalities. So yes. So is that a thumbs up from you, Dennis? What do you think?
Yeah, definitely. I think that the NHS 10-year plan actually is a good thing. I think it's going to be focusing on localized health, so around 300 community health hubs, which we hope will be able to address a lot of other issues, such as mental health, supporting people with rehab, and looking at generally at the social determinants of health. So I really do think it's a great thing, and I think also the focus on prevention and digital health, because going right now, and we just have to make sure that we don't leave anyone behind, especially in terms of new technologies. So I really do feel good about it.
Absolutely. And if only we had an expert on health inequalities and the NHS who's written a book all about it. Let's bring on Dr. Annabelle.
Hello. Hi, thanks so much for having me speak to you this evening, and also shaming me there, Susan. But yeah, it was correct. I was rushing desperately from clinic, but thank you very much for the kind words and the invite.
It's wonderful to have you on, Annabelle. Annabelle, so your groundbreaking book, Divided, that I absolutely recommend everyone reads, shines a really important spotlight on health inequalities affecting Black communities across so many different health conditions. And one of the health conditions where Black people are disproportionately affected and faced inequalities is HIV. What changes would you like to see in the NHS to address the health inequities affecting Black people?
Again, thank you so much for speaking so kindly of Divided, and a lot of it leans into kind of personal encounters within the health system through my own experience, family, patients and things like that. So I very much reflect on this through kind of what I've seen and anecdotally, but also drawing on research and what we know about some of these issues. And I think first and foremost, and this is some of what the 10-year strategy is mentioning, is that the investment in health services doesn't necessarily reach the right areas and the right people. And overwhelmingly, when it comes to a lot of these issues, they're overlapping with social inequality and issues of just general justice. So you can't really tackle them in silos, which for a long time is what people have been trying to do. So I personally would like a system that is much more joined up when we talk about we're talking about health, but also talking about society, and understanding why people can't come for testing. So when you're working in areas like I do, which we know have high areas of high social deprivation, we know that there's transportation poverty, work contracts when people are on 0-hour contracts, when people don't get paid if they don't come in, you taking a day off even if you know it's urgent, well, your rent's urgent. that
Yes.
precarity is very urgent. Like, of course, for somebody that doesn't live in that precarity, you might not necessarily get why you would delay coming for a test or why you wouldn't come if you have pelvic pain, but ultimately, being sacked would throw that person's whole livelihood into a tailspin. So I think for me, sometimes often you get told those conversations are too large to have, they're too macro, we don't have the time, we have to bite off what we can chew, we need to focus on screening and prevention. And I'm like, that's all well and good, but you really need to contextualize that and allow people to really marinate with the wider issues. So I think for me, it all starts there. I think building that level of understanding about the lives that live that are nothing like your own. I don't want to take too much time answering the one question, but I think, context is key for me. And making sure we have a holistic understanding of why we have these disparities in certain communities and how we perpetuate them on a global scale.
Absolutely.
That's great. Yeah, thanks, Annabelle. I want to bring in the subject of PrEP. So we know that uptake of PrEP in Black communities and particularly in women is very, very low from what we can see in the UK and in Europe, and as compared to white gay men, for example. And I just wanted to hear your views about this. What do you think that is the case?
Yeah, I think that first of all, another thing that I didn't touch upon is that some areas are over researched and we have too much research and we know that we have these disparities and we need to move forward with investment. And then there are other communities where actually we're under researched in the right areas in terms of our motivators and the things that are preventing us and challenges and that wider context that would lead us to take up PrEP more. I think from my personal experience and what some of the research shows us is that getting to clinic and the environments where PrEP is delivered are not always the places that certain communities want to go or would ordinarily go. So we have to upskill people in other areas, whether that's like general practice, whether that's like whether it's these new kind of community hubs and settings where people feel like they might have greater privacy or there might be greater normalization of these things. We talk about stigma a lot, and how that is still very much a thing. It's still very prevalent, even when we know that when you're on treatment, U equals U, and when we know that HIV isn't a death sentence, all of these things, it still carries that weight and that burden. We still have to keep challenging that all the time. There's also, I guess, provider issues, which I encounter on still a really regular basis. And this is not to say that healthcare professionals aren't often doing amazing jobs, but sometimes time's limited. It's only the obvious things that come to mind. And we're so well kind of taught, even within a sexual health sector, to offer even relatively low risk men who are having sex with men PrEP, because we're like, oh, there's a greater prevalence in this community, that when someone that is particularly Black African descent woman sits in front of us, we often don't even think to ask the question or make the offer. And if you're not offered something, you can't accept it. And it's definitely been under offered. I often sometimes ask colleagues if they thought of it, and they're like, oh, actually I didn't, and that's a fair point. And we're still having problems with the offering being there. And then also you as an individual recognizing that this is something that you need, and that's an education piece, but it's also so this is from personal and also just wider kind of cultural understanding, being of Nigerian descent. But often people's spouses or partners are abroad, or they're traveling across the continent, and they might be having other partners, and that pushes somebody to be more at risk of contracting a new infection, and not really engaging with that issue, or somebody raising that to somebody is definitely a massive barrier. So I've gone in a bit of I've not given you the best structured approach. Sorry, usually I try to structure it nicely into areas, but I hope that kind of gives you a bit of a flavour of some of the issues where people are contending with.
Absolutely. Yeah, no, thank you so much for sharing that, Annabelle. And I think you're right. And so often in Black communities, we're just not having conversations about sex. Anyway, I'd like to say that my 73-year-old auntie is watching the show today and knows about PrEP and has these conversations, I hope. But I think it's just getting around the mindset that, like HIV is something that can affect anyone. So, hopefully the message will get out there more effectively.
And just to say on that front, that it's an interesting one. I don't want to kind of culturally homogenize, a whole continent or whatever, but I'll speak from my kind of perspective. Nigerian culture, actually they might dispute this because we've got quite a Christian religious culture, but it's very highly kind of sexualized culture actually. But then on the one hand, we'll be really overt with some things, but won't have conversations about other things, and I think it's also about addressing that directly head on with people, sometimes saying, well, you're really open to the fact that your partner's got all these other partners, but then you're not engaging with the sex education piece because that's a bit much for you, and let's think about it.
Yeah, no, absolutely. Yes. And Annabelle, I'd like to move on to another area of health inequity that we see, which is maternal outcomes, with Black women being 3 to 4 times more likely to die in pregnancy and childbirth than white women. What would you say is driving this?
Yeah, so I'm quite open at the moment about the fact that I have a 1-year-old, and I went in knowing a lot of these things, advocating for these things, and then despite this had a really bad delivery actually, and it gave me a different level of understanding of the issue. So again, personal, but also kind of what I've learned from working in the space, that there are so many things, but there are a few things that crop up regularly and were also very much the case in my circumstances, that you're extremely vulnerable when you're in labor in particular, but pregnant generally. We see, that's when domestic violence rates go up, all of these things. It's much more difficult to advocate for yourself, and you can't do a lot of the things that you would usually do. And you're kind of out of your body during labor. And unfortunately, we see repeatedly that women across the board, people who are giving birth across the board, feel like they're silenced and not listened to, and they can't really even articulate themselves as you would expect in the way that they want. But this is 10 times fold for people that other people often wouldn't ordinarily necessarily, because of all the things we know, take seriously or be particularly attentive to. And it's magnified when you're in labour. And this is something that comes up, you know, from surveys that have been done, from policy papers. So I'm a trustee also at Birthrights, from 5 Times More survey, that we see people saying that, oh, I had this delivery, and I was saying again and again and again from when I came in that I wanted the epidural early and I wanted it. And it was like nobody was hearing what I was saying, and I just kept on repeating myself. So this is definitely something that we need to address in terms of why it is that some people, obviously we know in society more widely, are heard more loudly than others, and how we factor that into our management and our healthcare systems, and try to get people to challenge what they would ordinarily do in some situations. So that's one of the kind of key, I think, repeating issues. But then it's all the other things I mentioned as well. So when you look at the Embrace report, where we get a lot of these statistics from as well, disproportionately this group is affected by other issues. So like mental health issues, presenting maybe later, not making it to antenatal care, some other factors, which are also, you know, those are structural factors, right? Like, why are those, a specific demographic, not able to get healthcare in the same way, and then it escalates. And the last thing I will say, as a community sexual reproductive health consultant, we talk about childbirth, but we talk about reproductive health throughout its life course. And we see these disparities at every kind of phase of the reproductive years, right up into menopause. So it doesn't just happen in childbirth by, you know, it doesn't just happen there. It started with menarche, you know, and how people are treated when they present, and it takes their Black woman on average to get diagnosed for endometriosis or something like. So it doesn't just present, it was all the stuff that happened beforehand.
Thank you.
That's really, really helpful. A lot of very insightful points there you've raised. Just finally, you know, just quickly, I know you've alluded some of this in terms of looking at some of the cultural issues in West Africa, which I think reflects also what we see in West Africa. I mean, in East Africa and in Central and Southern Africa as well. But I just wanted to ask, you know, maybe this is not just an issue of community, but also clinicians. What do you think? How can we change the mindset in healthcare service provision so that Black communities can achieve optimal healthcare? And you know, that this speaks to both sides, you know, ourselves as a community and maybe also clinicians, you being a Black clinician as well.
Yeah, so I think it's such a massive question. I think, first of all, currently our current health system is quite unstable in terms of post-pandemic, but even beforehand. And often what we see in these unstable systems that aren't well staffed, that communities that are marginalized then do worse. And so I think really to make our health better, we really need to kind of stabilize the overall health system, which sounds very big, but ultimately we will lose when we have 10-minute appointments. We don't have, because you need to do a lot of work to get to your diagnosis in this current health system. And if you can't advocate for yourself, or you're easily dismissible for all these other reasons, we're still going to have the worst outcomes. So the best thing we can do also is engage with overall what's happening to NHS services, you know, as a community, like be quite politically engaged, mobile, you know, make sure that we, you know, vote and things like that, because ultimately we actually lose out most heavily. And when it comes to healthcare professionals, I think honestly and truthfully, I think it needs to be embedded in our education system from the offset. We need to be health literate from school. And we need to teach, you know, how to navigate health systems very early on. It needs to be a key part of kind of our educational system. And I think it's missing, to be quite honest, and people don't understand until they have a problem and it's far too late. So I really think we also need to do work in advocating for that to happen and involve ourselves in just general wider education.
Brilliant. Thank you so much for coming on, Annabelle, and sharing your really important insights. So glad that you made it.
Thank you. I'm so sorry.
Thank you.
Yeah, brilliant as always. Thank you.
Thank you so much.
Yeah, but really important points that Annabelle raised, and just thinking a little bit about PrEP. Dennis, I believe that you are currently doing some work in relation to PrEP and migrant communities.
Yeah, so recognizing the gaps in PrEP provision generally in Europe, there's a huge gap in PrEP coverage. A lot of countries still don't have guidelines on PrEP concerning migrants and even undocumented migrants. So we are carrying out a survey. We've done a European-wide survey in 14 countries that are looking at PrEP and migrants generally. And we are doing another survey right now. So the first general one is funded by Gilead. We've been able to do that and complete it. We're analyzing it. And we have a specific one by Viv Healthcare that is looking at PrEP and women. So yeah, we're waiting for very good results, I believe.
Fantastic. I'll be looking out for that. But Annabelle is not the only guest that we have who's a tremendous writer. Let's bring on Angelina.
Hello.
Hello, Angelina. Wonderful to have you on. So thinking about like absolutely brilliant books, I've got to say Our Stories Told by Us is one of my favorite books that's ever come out. And it's not just because I'm in it a little bit as well. It's absolutely fantastic. And it's had a huge impact all across the world. How important is it for Black communities to tell our own narratives?
Well, Susan, firstly, thank you very much for inviting me to come on, and thank you for the kind words about our stories. So, in terms of how important it is, well, I think it's incredibly important. This is because if we don't shape and tell our own narratives, then someone else will do it for us. And we know how that has gone down over the years. So it's the very reason why 5 of us African migrant women living with HIV, so Charity Nyirenda, Memory Sachikonye, Rebecca Mbewe, Winnie Seruma, and myself decided to co-author and co-edit our book, which is called Our Stories Told by Us, celebrating the African contribution to the UK HIV response. Now, amongst many other reasons, I wanted to change the narrative about how African people living with HIV are often written about. Usually it's in the negative. We are portrayed as victims and passive recipients of services. And so what we wanted to do was to change that narrative, to celebrate our achievements and show that we've always been here, resilient, leading, and equally contributing to the HIV response, alongside many allies and stakeholders. But we also wanted to challenge wider stigma as well. And most importantly, we wanted to tell our stories in our words, in our way, because if we didn't do it, somebody else would do it for us in their words. And so we just wanted to make sure that we shaped and told our own narratives.
Wonderful.
Thank you, Angelina. It's really wonderful, very inspiring work you've done. I'm going to combine my questions. There were 2 questions, but I just want to combine them so that you can answer them at once. So that you have enough time to speak. I wanted to ask what advice you'd give a Black woman who is living with HIV regarding their mental health and well-being, how they can care. But the second part of that question would be the same. What advice you'd give a woman who is newly diagnosed with HIV?
Okay. So in terms of firstly, the advice to a woman, experiencing mental well-being and being unwell in terms of their mental health, the first thing I would say to her is your mental well-being matters. And secondly, there's absolutely no shame in seeking support for your mental well-being, especially when things are not going so well. Many of us come from cultures where mental health is a taboo subject, right? So what I would say to this woman is ignore those messages, talk about it, get support, because many of us experience periods of where mental health is not being so good. But I'll also say to her, learn to be aware, to take note of when things are getting on top of you, and to get support. because there are different types of support out there, ranging from peer support to professional psychological support and also to treatment. So you need to find out what works for you. And there are also lots of online resources. Find a reputable one. So, for example, I'll just give one example of the Mind Charity, which has a really, really useful website full of practical resources. And I think finally, on that point, I'd like to just give a shout out to our video resource, Susan, Nature and Mental Health, where you and I talk about the mental benefits of nature for women living with HIV. And this is available on our forum website, which is at 4mmm.org.
It's amazing.
So your second question was...
The second question to the same, what advice would you give a woman who is newly diagnosed with HIV? Because new diagnosis is always very...
It does affect your mental well-being, doesn't it, for many?
Yes.
Right. So the first thing I would say to them is you're not alone. There are many of us living with HIV. The important thing is to speak to other women living with HIV, because I remember myself when I was diagnosed many years ago, I felt like I was the only woman in London living with HIV. So find somebody, talk to someone else who's been through that journey. There's a lot of power in the peer support that can be provided by another woman who's walked in your shoe, who has been through that journey of diagnosis and then learned to cope. And also tell her that HIV has changed. And Annabelle has alluded to that. It's no longer that death sentence that it used to be. We now have incredibly effective treatment for HIV. So effective, in fact, that we've got to a point where we can say with confidence that U equals U. And again, Annabelle alluded to that. And U equals U just stands for undetectable equals untransmittable. And so in simple terms, it just means someone who is living with HIV takes their medication every day, on time, and as advised by a healthcare provider. If that person achieves and maintains an undetectable viral load, and viral load that just means the HIV virus in your body is very well controlled, that person cannot pass HIV onto a sexual partner. So U equals U is a complete game changer. And finally, I'd also say that with access to treatment, to care and support, we can have relationships if that's what you choose. You can start a family if that's what you choose. We can have babies born without HIV if that's what you choose and you're able to. You can work and you can live your best life just like other people who do not have HIV. So simply put, in terms of this newly diagnosed woman, I would say to her, women living with HIV are just like you and me. We're friends, we're lovers, some are wives, we're sisters. No, we're just regular people and it will be well.
Fantastic. Thank you so much for sharing that, Angelina. And we have made such extraordinary progress in HIV, but one area where women, and particularly Black women, are being left behind and are underrepresented is in medical research. And I completely understand why some people would be reluctant to get involved in research. But why do you think it's important that our communities actually take part in research?
Well, it's really important for so many reasons. I think the first reason is when our communities take part in research, it empowers those communities to participate in addressing our own health needs and the health disparities, whilst also ensuring that researchers actually understand what our priorities are. When we as communities participate in a research study, or you, for example, you're contributing to discoveries that can benefit society, whether it's medical research, social sciences, or environmental studies. Your or our involvement helps scientists to answer important questions. The other reason is that it ensures that treatment is tailored to our needs. And so with all that in mind, it's really important that we as African community, Black African communities, are involved in research at all stages, from coming up with the research question, designing the research itself, being part of the study team, leading on the PPI, which is public patient involvement elements, contributing to and reviewing study materials, being co-authors on resulting papers, and being also actively involved in the dissemination of results, but also in ensuring and advocating for communities who are directly involved in the research to actually benefit from it. So, for example, if research is being done on an effective new drug, ensuring that those communities who took part in the research actually have access to the medication when it becomes available on the market. I want to just stop and give a like a shout out again to a paper that we wrote at Foreign Plus Our Allies. It's called From Presumptive Exclusion to Fair Inclusion, which is a paper about the meaningful involvement of women living with HIV in research. What it does, it contains perspectives of women living with HIV and other stakeholders involved in research. But I also want to give another shout out to the Share Collaborative. They are based at Queen Mary's University in East London, which is where I live. So this is a collaborative that conducts research for health equity. Share brings together clinical, biomedical, social science, and community expertise in infectious diseases to actually investigate the inequalities that lead to poor health outcomes. And what they do is that they aim to make sure, as Janice alluded to earlier, that no one is left behind. This is an excellent example of how to do great research with and in communities. And last but not least, the reason why our communities should get involved in research is because it benefits us as individuals, firstly. It also benefits our communities, and it benefits our future generations. They are perfectly embodying the spirit of Ubuntu. Ubuntu is a South African term rooted in humanity. In full, it stands for Umuntu Ubuntu Kabantu. It just simply means we are who we are because of others.
Oh,
That's amazing. That's really, really good.
That's so wonderful. And do you have a tattoo, Angelina, that says that? Yeah, I've got very close and see. So she really does mean it. Thank you. Thank you so much, Angelina, for coming on.
You're very welcome. Thank you for having me on.
Thank you.
Thanks.
Bye.
Yeah. Bye-bye.
Oh my goodness. Absolutely such important insights from Angelina, and I love it. That's talking about certainly in terms of something you believe, showing it as a tattoo. How cool is that?
It's really inspiring. I mean, she's been an inspiration. Yes. Thank you.
So I think we are actually, oh my goodness, I'm enjoying this so much, but we're out of time. Thank you, everyone who's watched today. Thank you to Annabelle and Angelina for coming on the show. You are absolutely brilliant. Thanks to Disruptive Live for all of their technical wizardry and making us happen. And do please join us next month for the next episode of Positive Health. It's going to be streamed live on the Phoenix Health Movement YouTube channel. So do please subscribe for updates, and we will see you then. Thanks very much.
Thank you very much. Bye-bye. Bye.
Bye.